Welcome, everybody. Good morning. My name is John Abraham, Jonathan. I go by either. I am one of the faculty members at Cornwall Health, MSU, and it is my privilege to share with you this morning a conversation about cardiac arrest in the palliative care considerations in this patient population. Some of the things that we're talking about today overlap with some of the lectures that we've already had. This is a somewhat technical talk, diving into some of the advanced therapies, treatment modalities for these often very sick patients. And we'll talk a little bit about the considerations from a palliative care perspective and how we can best have goals of care conversations in anticipation of a potential unfortunate event such as cardiac arrest, inform our discussions about code status. What does that really mean to have CPR outside of the hospital when we're completing an out-of-hospital DNR form? Part of my motivation for making this talk was to help my own understanding for these very complex patients that we're sometimes tasked with supporting during a critical illness. So without further ado, let's dive in. And I have nothing to disclose. Our learning objectives today are to understand the current state of cardiac arrest care and its implication in palliative care. We're going to get a basic understanding of advanced heart failure interventions, particularly ECMO and its permutations. And then we're going to talk a little bit or gain a little bit of understanding about the relevance of ECMO and the palliative care provider. So I'm going to start with a case. Is a real patient. The patient that we're talking about is a 63-year-old female with pulmonary sarcoidosis who's hospitalized for increased work of breathing, acute hypoxic respiratory failure. Her hospital course is complicated by an in-hospital cardiac arrest. She underwent several rounds of ACLS and endotracheal intubation before they got her pulses back. Despite this, she was in persistent cardiogenic shock and respiratory failure on a ventilator. She was ultimately cannulated for VA ECMO. We'll talk a little bit about what that means. And the ICU team is ultimately able to stop her pressors and extubate her successfully, but she remains on ECMO as she awaits a lung transplant. So without knowing anything more about the case, which we'll get back to, what's your general feelings about, potential outcomes or palliative needs for this patient? So while you're sort of mulling that over, let's let's take a step back and talk a little bit about, where we are today in the, treatment options and care for these patients and how do we get here? So I think it really helps to understand where we are right now and how we got here. And I want to talk a little bit about the current state of cardiac arrest in the United States. For a long time, we had no idea what was happening outside of the hospital with cardiac arrests. And as the advancements in emergency medicine, which is my background, I'm emergency medicine board certified prior to my palliative training. These patients came in sick, and obviously, cardiac arrest, CPR in progress, by EMS or started by family members, in the home. And for a long time, we had no idea, what worked, what didn't, what happened to these patients in the pre-hospital setting, in the hospital, and afterwards. And so a couple of years ago in 2024, so 20 years ago, I guess, this was identified as a major gap in our knowledge, and a database was founded, the Cardiac Arrest Registry to Enhance Survival, developed by the Department of Emergency Medicine at Emory University in Atlanta. In 2005, they registered 600 cases of out-of-hospital cardiac arrest, and then, flash forward to almost 20 years later, they're capturing 2,800 cases weekly. So it started as sort of a local database. This has really turned into a national database, netting something along the lines of 350,000 cases annually registered in the United States. And so this is a multiple state initiative now. It's not quite all 50 states, but Michigan is one of the participating states. And so I'll share with you some of the data that is shared in this pretty comprehensive report. The current state of non-traumatic cardiac arrest care. Obviously, trauma patients are different, are categorized differently than medical cardiac arrest patients. But from 2013 to 2022, they recorded 876,000 out-of-hospital cardiac arrest cases. 46.2% of those underwent bystander CPR. And the overall survival rate for these patients was 9.2%. So how they define survival is survival to hospital discharge. So, like I said, Michigan is one of the states that participates in this database, in the CARE Survival Report. You can look this up yourself. But, one of the questions is, well, what does survival mean, right? I mean, assuming they have a pulse, they're able to leave the hospital in some form or another, but the devil is in the details. And so this is obviously a busy slide, minuscule font. I don't expect you to be able to zoom in and read this, but I will zoom in to the things that stand out to me. So this is just the Michigan folks. This is pulled from, I believe, 2022. Again, lots of numbers here, but I circled the number that I want to focus on, and that's people are surviving to discharge. Now, this is adult populations. I know we have pediatric providers here, so this is just adults greater than 18 years old. So we have 9,000 patients in this 2022 study. And they found that 6.5% of those, so a little bit under the average from the national data, survived to hospital discharge. And you'll see it says you may be able to read, it says survival to discharge with a CPC of 1 or 2. So CPC stands for Cerebral Performance Category. It is your neuro status following a cardiac arrest. It's spun off of the Glasgow Coma Scale, but it focuses on cognition. So a CPC-1 is most of us, depending on if the coffee is kicked in yet, are a CPC-1. You're conscious, you're alert, you have normal function, maybe you have a slight disability. I didn't sleep well last night. I wouldn't claim that as a disability, but I think the CPC-2 is where things get interesting. So they define it as conscious and alert with moderate disability. Okay, so what's moderate? I'm reminded of one of my professors in med school say, well, what's the difference between minor and major surgery? He said, well, it's major if it's happening to me. It's minor when it's happening to everyone else. So CPC category 2 is a little bit like that. So moderate disability. So they say it's conscious with sufficient cerebral function. So you're capable of doing part-time work in a sheltered environment or to do independent activities of daily life, like dress yourself, travel by public transportation, prepare food. But you may have hemiplegia, seizures, ataxia, dysarthria, dysphagia, or permanent memory or cognitive changes. So, all of a sudden that 6.5% represents relatively normal or pretty impaired. They say moderate disability. Well, if I could only work part-time and was able to ride a bus independently, that would represent a pretty significant change from my current baseline. And so I think it's important to think about as we talk about patients and and outcomes of these interventions, namely CPR. Obviously, CPC scores of 3 and 4 are severe disability. But there is all of a sudden we're sort of seeing these tiers of people with palliative care needs. So it's kind of a bummer, man. I mean, it's hard to sugarcoat this. Um, but it's not hopeless, because we know things work. So what works? So early CPR, defibrillation works. These are class 1 recommendations by the American Heart Association. This is, the literature is very strong in supporting that AED use, defibrillators. This is why there's a defibrillator in every airport, every mall. I feel like I've seen them, 7-Eleven or McDonald's. This is why that, or high schools, gymnasiums, because they know that shocking people out of shockable rhythms leads to better outcomes. And just to quote, the only rhythm-specific therapy proven to increase survival to hospital discharge is defibrillation of VFib or pulseless VTAC. Epinephrine, if any of you have been participated in a code situation as part of your medical training, we're the nurses, the docs, the techs are calling for epinephrine every 3 to 5 minutes, a dose of epi. This is notably a class 2B recommendation, which is not strong evidence to support its use, but the recommendation, the language is changed slightly. It says using standard dose epinephrine may be reasonable for patients in cardiac arrest. It's not super confidence inspiring. The original data to support epi came from research in the 1960s on animal models. They induced cardiac arrest on beagles, which is, as a dog person, that's kind of brutal. So 10 out of 10 beagles who received ventilation, compressions, and epi achieved ROSC, or return of spontaneous circulation. In the article here, there was a discussion that 1 milligram worked for dogs, so adult humans may need higher doses. And so this is where we sort of have interpolated the data to use higher dose epi in our code situations. In 2018, they did a randomized trial of epinephrine use in out-of-hospital cardiac arrest. This was a large placebo-controlled, randomized controlled trial that looked at epi with almost 8,000 patients enrolled. And the conclusion was that epi kind of works. It had a significantly higher rate of 30-day survival than placebo, but there was no significant difference between the rate of favorable neuro outcomes because more survivors had severe neurologic impairment in the epinephrine group. So again, it's I guess there are some encouraging bits of data coming out of our the current standard of care, but the question is, well, what could we be doing better? The heart, the lungs, cardiopulmonary resuscitation is very complicated. I have I'm coming from emergency medicine, spending a lot of time in the ICU. Even I have a lot that I don't understand in this area. So I try to simplify things with cartoons. So the normal circuit here: smiley face, happy body, happy patient. Starting at the top, the blue RA. So we have the right atrium, the right ventricle going around in a clockwise manner to the lungs. So we're pumping blood throughout the body. So the lungs oxygenating blood to the left atrium, to the left ventricle, which pumps into the aorta, which perfuses the tissues. And then they use up the oxygen and send that deoxygenated blood back through the IVC or SVC back, and we start it all over again. And this is the unhappy circuit. Okay, any break in the circuit can lead to cardiopulmonary collapse, hemodynamic instability, hypoperfused states, and many years ago, there were some smart people who raised the question, well, what if we could bypass a broken circuit? And this happened in Michigan. Dr. Dodrell at Harper Hospital in Detroit worked together with engineers from Ford to create the first cardiac bypass machine. And this is a photo of the machine and some proud gentlemen standing around it, and you can tell it came from the Ford Motor Company because it looks like a V8 engine. In fact, these guys look like they're standing over a car at a car show. But very cool. This was a news clipping from the local newspaper about this robot heart keeps a patient alive for 50 minutes during a cardiac surgery. So pretty cool. So that was years and years ago. Okay. What about now? So I want to talk a little bit about the different, I guess, care interventions, advanced therapies for patients who have suffered cardiac arrest, who are in persistent cardiogenic shock, who have impaired cardiac function. So the LVAD, the left ventricular assist device. This is important for us to know about because a lot of centers who place these devices have protocols in place that patients, before they undergo LVAD implantation, are to be evaluated by palliative care to talk about their goals of care. Because there's a lot that goes into this, these interventions. So an LVAD is a device that both exists inside the body and outside of the body. We talk about these different interventions as a sort of bypassers or boosters. So the LVAD is a booster. The heart is impaired. It can't pump blood the way that it should. And so it's a pump that exists inside the body. There's an internal pump. It takes blood from the ventricle and pumps it straight into the aorta, gives it that forward flow. And there is a power supply that exists outside of the body. So the power cord or the drive line connects the external battery and controller. So like, the remote control that can interrogate the pump and do all the, setting changes and whatnot. Those exist outside of the abdomen, but you have people wear a battery pack. And there's a lot of lifestyle considerations that come along with an LVAD, like people aren't allowed to submerge themselves in water ever again. And for people who live in Michigan or have a house, cabin up north on a lake, that's a pretty big deal. So they have a portable battery unit on their belt or in a bag, and then they have a power base station at home. I want to talk about the Impella device. You might encounter these in patients, typically in the ICU. This is sort of the world's smallest heart pump. Again, it's the boosters and the bypassers. So this is a booster. It is typically fished. It's a catheter implanted device. It's fished up the femoral artery into the aorta, and so it basically sucks blood out of the ventricle, and there's an output flow straight into the aorta. So it again boosts the cardiac output artificially. This one, the intra-aortic balloon pump, or just simply balloon pump. This is a device that is also sort of implanted via catheter. And it basically is what it sounds like. It's a device that sits in the aorta and has a a balloon that inflates and deflates. It inflates in diastole and deflates in systole. And if you remember some of your cardiology, diastole is when perfusion gets to the coronary arteries. So certain, cardiomyopathies or, acute coronary syndromes, the coronary arteries are not perfusing well. And what this balloon does is it increases the coronary artery perfusion pressure and map the mean arterial pressure by inflating. The blood cannot eject the heart, so it backflows into the coronary arteries, giving them more blood flow, and then deflates during systole, so the heart can have the normal sort of ejection of blood into the systemic circulation. ECMO. Okay, this is a sort of the flash forward, the modern day version of the bypass machines. So, we talk about boosters. The devices interventions on the prior slides were more of the booster category. This is a bypass category, okay? And pretty complex. They're all complex. ECMO is its own flavor of complexity. ECMO is sort of a blanket term for extracorporeal membrane oxygenation. I like ECMO better. It rolls off the tongue a little easier. And there's two flavors of ECMO. So VA ECMO is heart-lung bypass, and VV ECMO is just lung bypass. So VA ECMO, veno-arterial ECMO, is the heart-lung. It's primarily for cardiac failure, so cardiogenic shock patients, pulmonary hypertension. These patients may be receiving ECMO as a bridge to heart transplant. Versus the veno-veno ECMO, VV ECMO is primarily for pulmonary failure. So in COVID patients who had, shredded lungs, ARDS, we would sometimes see those patients on VV ECMO. People who have, who have advanced COPD, emphysema, pulmonary fibrosis, who are waiting lung transplant might be on VV ECMO. Or if somebody has, an airway disaster, a bad trauma, might be on VV ECMO. And so, these are some of the technical things, but these are photos of ECMO in practice. Okay, kind of bloody, kind of intense, especially that left photo. You see two physicians or practitioners cannulating the femoral vein and the femoral artery to hook up to an ECMO circuit, and you can see a lot of materials, a lot of blood involved in cannulating somebody for this intervention. And then on the right photograph, a little smaller, is a representation of an ECMO circuit. You're at the bedside and you see these big hoses with blood flowing through them. These are some of the components of an ECMO circuit. I don't want to bore you to tears with the technical specifications of what compromises an ECMO circuit, but basically, it's everybody's favorite term: semi-permeable membrane. Okay, so blood is sort of washed over a blender, an oxygen blender, which adds oxygen to the blood and simultaneously removes carbon dioxide from the blood. And so blood goes in, it's basically acts as lungs. So this is sort of representative of VV ECMO. So we revisit our cartoon. See on the left here, we have the broken circuit. Okay, the normal perfusion cycle of the human body. and this bypasses the break in the circuit. So blood goes into the ECMO circuit, deoxygenated, and comes back full of oxygen straight into the aorta. The VA ECMO gives forward flow into the aorta to maintain like adequate blood pressure. So the heart isn't working, the lungs aren't working. So it's oxygenating the blood and giving forward flow to move that blood throughout the body. Um, so why ECMO? I mean, what's the utility? Why do we do these things? Um, well, the data is pretty exciting. We touched a little bit about, what works and what doesn't, and a little bit humbled to think about all the things that don't work so great, right? We think about those cerebral performance scores. They don't look very good. Um, and the early data coming out of ECMO or ECMO boosted or ECMO supported CPR or eCPR for refractory out of hospital cardiac arrest. So the survival rates are a little bit more encouraging. Now, you might be thinking to yourself, you see the survival rates of 4 to 55%. I mean, I read the same papers that you do. I don't totally understand what that means from a statistical standpoint when you have a range that broad of 4 to 55%. But, you know, it seems like it would be better than the 6.5% that we're seeing out of the Michigan data from 2022. And shout out to Michigan, last year was 8.5%. So we're getting better, everybody. But eCPR is, there's a lot of data, I mean, a lot of research going into this because people are excited about the promise. In fact, so encouraged that out of hospital ECMO cannulation is now a thing and being utilized in Paris, among other sort of European cities primarily. And so the photo I showed you before, a couple slides back, of the two women cannulating a patient for ECMO was actually taken. This is a different angle of the same photo taken on the Paris metro. This patient had a cardiac arrest in the subway and was deemed a candidate for ECMO cannulation. So they did it right there on the subway platform. So, like all the things that we do, the amazing things that medicine can provide to support a sick or failing body, there are significant risks associated with these interventions, significant comorbidities that may impact or inform the work that we do in caring for these patients and these families. So obviously ECMO is reserved for the very sickest patients. During the COVID era, the early pandemic, the patients who were crashed on ECMO were obviously the sickest in the hospital and did not do well. In fact, a lot of centers stopped cannulating people for ECMO and COVID-associated ARDS because the mortality was so incredibly high. And independent of the COVID numbers, the in-hospital mortality for ECMO, a patient supported by ECMO, is 63%. So most people, not the vast majority, but most people, the majority of people supported by ECMO will die in the hospital. To maintain an ECMO circuit, they need to be, in a super anticoagulated state. They have to have a super therapeutic INR to maintain the ECMO circuit so it doesn't clot. And we do see clotting in the ECMO circuit, despite super anticoagulating these patients. And when you overdose people on anticoagulants, they bleed. So there's a bleeding risk. I've seen a patient be decannulated accidentally while going to a scan, the ECMO circuit unhooked, and that, trust me, that looked like a horror movie. Thankfully, they were able to reattach the circuit, but yeah, it can be pretty dramatic. You can have pump or circuit failure. The pump can clot. There can be technical issues. We don't have a ton of circuits. Like, how do you troubleshoot it? These are very complex machines. Is somebody on hand 24/7 to troubleshoot these things? Um, we see limb ischemia in these patients. Whenever you're messing with large vessels in the body, you may be compromising the normal function of these vessels, and we see ischemic limbs, lower extremities primarily, and they could be dramatic. They could have gangrene. They could have compartment syndrome of the lower leg that needs big like fasciotomies. So all of a sudden, not only do they have a heart-lung problem, their leg is flayed open, and they have complex wounds with maybe impaired healing due to hypoperfused state. Neurologic injury, similarly, they could have bleeding in the brain. They can have hypoperfused states that cause neuro injuries, infection, and then pain. I mean, we look at those slides of the ECMO cannula being placed in the subway. I mean, it's quite bloody. It's quite gruesome. It's much more invasive than, say, like a central line. They have to cut down to the vessel, cut open the groin to place these things. And I can only imagine that hurts. So I want to revisit the case that I shared with you in the beginning of the talk. This is actually a patient I cared for at Henry Ford when I was a fellow. So this was the patient who was awaiting lung transplant due to pulmonary sarcoidosis, who had the in-hospital cardiac arrest, supported on VA ECMO due to persistent cardiogenic shock and hypoxic respiratory failure. So she was on VA ECMO for several weeks while she was awaiting a lung transplant. During the 5th week of her hospitalization, the patient was noted to have a hemoglobin drop, and she went to CT imaging, and a large retroperitoneal hemorrhage was noted on her CT. IR was consulted to see if they could embolize something. It was not deemed to be, a lesion that was amenable to IR intervention. And unfortunately for this patient, due to the complication, the bleed, she was bumped off of the candidate list for lung transplant surgery. So, super anticoagulated state, had a spontaneous retroperitoneal bleed, and that was enough to deem her not a candidate for lung transplant. And you may remember from a couple slides ago, ECMO is not a bridge. It is bridge, not a destination therapy. We don't have patients live on ECMO forever, whereas LVADs, may be a bridge to a heart transplant or may be a destination therapy. You just may be on an LVAD for the rest of your life. This lady was on a bridge to transplant that she was no longer a candidate for. And as a result of this, it was identified that ECMO was no longer a viable treatment option for the patient because it's never a destination therapy. And so after a family meeting, it was shared, this devastating news was shared with the patient, and that decision was made to discontinue any further life-sustaining therapies. This patient was transitioned to comfort-focused care, and she died approximately 20 minutes following ECMO discontinuation. And this case was quite sad, but also notable because I was involved in her comfort care transition. We do ventilator withdrawals, not infrequently in the hospital setting. We're pretty good and pretty adept at managing distressing symptoms that come with extubation or stopping vasopressor medications, life-sustaining therapies. This patient posed an interesting challenge because, VA ECMO, like I said, it oxygenates the blood, but it also gives forward flow. It's a bypass and a booster. I think one of the challenging things is that, when we were weaning or stopping ECMO, we lost forward flow. And what that meant for our symptom management is that we would bolus the patient with fentanyl or Versed, and we weren't confident that it was getting to her central nervous system because her cardiogenic shock was so profound. And so we were pushing a lot of meds, but without confidence that it was getting into the central circulation. So she was more symptomatic than we would have liked, despite aggressive dosing. And, having had this experience, which was okay. It wasn't as, as traumatic, I think, as it could have been, but it could have been better, certainly. And there is some research into, what ECMO does to these medicines. ECMO may sequester the meds that you're providing. Some meds may sequester more than others. Um, and the literature out there is not expansive, and so sometimes we're making our best guess on these things. But if you ever encounter a patient like this, I might encourage you to be a little bit more generous with your dosing, with the understanding that things, you may lose the opportunity once the circuit goes down to get those meds to the central circulation, and you might need higher doses than you otherwise would utilize, based on the possibility that the circuit is sequestered a little bit. Uh, so a tough case. Another case that we encountered here at Corewell raised some pretty almost like philosophical questions. How do we approach goals of care in a patient when we don't really understand, or our definition of what we think we understand is life and death is sort of sent in head over heels. So we had a patient, a young man, who had a devastating out of hospital cardiac arrest. He had been at Disney World in Florida with his family. This was like a trip that had been planned for years. Multiple family members. They had a great time, but he started feeling unwell in this trip, and returned to West Michigan, and unfortunately suffered a cardiac arrest shortly afterwards. They suspected that he had an acute coronary event that probably started in Florida, and he was late to have this evaluated, and had a massive cardiac infarction, resulting in probably VFib arrest, which then in turn turned into PEA arrest. So this patient was crashed on a VA ECMO in the hospital, and was basically on a ventilator, receiving perfusion with the ECMO circuit, but had no neurologic function, essentially. And his telemetry monitor was essentially PEA arrest. He was in a persistent state of minimal to absent cardiac activity. I was there with one of the ICU fellows at the bedside. They put an ultrasound probe on this man's heart, and it was basically in a cardiac standstill. And this had been for days. Okay. And we were brought in to have a goals of care conversation with the family. I was a big family, just come back from Disney. This young father was, enjoying his time with his family, and then he was just gone in this state. And it was hard to, part of our job in goals of care conversations is to explain what's going on, right? Help patients and families understand their pathology, their prognosis. And this was really hard. Is this patient alive? Is this patient dead? I mean, he's warm. His oxygen sats are great. His heart isn't moving. We define death, like a clinical definition of death is like a cardiac death or a brain death. We had not yet started down the brain death pathway for this gentleman, which ultimately is what happened. He was declared brain dead. But we hadn't gotten there yet. So how do we talk about prognosis, like current uh, you know, how do we manage expectations, prepare people for, a very unfortunate reality, without the terminology, without the real true understanding of what defines life in a bypassed state. This body was broken. The machine worked fine. It was doing what it was supposed to do. But what are we really talking about at the end of the day? And I was reminded, I'm a big movie fan. I'm reminded of The Princess Bride. You have Miracle Max here saying there's a big difference between mostly dead and all dead. Mostly dead is slightly alive. Sorry, it's my best Billy Crystal I can offer. But, it's these are really complex cases, and redefine our understanding of, uh, life and death. So I leave you with another photo from Paris. I don't know if it's the same exact team, but this is a patient who had a cardiac arrest at the Louvre, um, uh, uh, and was cannulated for ECMO in the museum. Um, you know, I I don't know about you. I mean, having a massive cardiac arrest at the Louvre sounds better than having a massive cardiac arrest at an LTAC or something. That's just me. That's my personal take. But this is the world that we're living in, and I think it behooves us as practitioners, as providers, um, uh, to know about these things as we go forth into the world to care for patients who may be supported by these interventions. So um, that's all I have for you this morning. I thank you for your time. And as always, we can open it up to any questions, comments, personal experiences. I will mute myself. And if anybody has, wants to put questions or comments in the chat, we can do that too. So thank you for your time, and thanks the fellowship leadership for having me. It was a lot of fun.
Thank you, John. Appreciate it. This is really, I thought, interesting and just on a lot of levels. I wanted just two things that I really wanted to address. The first, just kind of last one, we were talking about difference life and death, and it just kind of, I was reflecting on conversations we've had around the ethics committee there at Corewell, and about the donation for transplant, DCD is what they call it, donation after cardiac death, is what it's called, but technically it's diagnosis after circulatory death. And that has raised some very interesting ethical conversations, not just within our community, but nationwide, in terms of exactly what does circulatory death really mean. So if someone is declared dead on the basis of their circulatory incompetence, and now we have reestablished their circulation for the purpose of being able to procure organs, have we, in a sense, reverted them from death back to life because we have claimed them to be circulatorily incompetent, but now we have restored them again. So it's a fascinating, and it just hurts your brain to think about it. So I appreciate that you putting that on the table. And the other one, this is a more practical question. I'm going to dig down a little bit more if you can help us with some practical suggestions. I have observed in a number of different clinical settings that we significantly need to escalate our opioids at the end of life when we see circulatory compromise, for the very reason you suggested. We're not getting the drug to where it needs to be. Do you just sort of go with your gut, or do you have a specific algorithm that you follow when you're looking at that sort of a scenario?
That's a great question. I think it's a combination of a couple of things, at least in my own personal practice and practice that I've seen employed, basically in my fellowship training at Henry Ford, which, there was, that's a transplant center, similar to Corewell, transplant center, LVAD center, a lot of sort of complex sick patients. So, the gut answer is that when you don't know, be a little bit more generous. So how I have approached patients who are on ECMO similar to how I've approached is how I similar to how I approach patients on like high dose vasopressors. And there's a plan to extubate a patient or stop, their pressors. You just don't know, what the circulation, what um, their basically mean arterial pressure is going to do after you remove these interventions. And so when you don't know, assume the worst. And so what I will often do is pre-bolus in generous doses before those interventions go away. Just to be a little bit more confident that the meds are getting where they need to go, the central nervous system. And then, when you're a little bit more confident that they have reach the therapeutic level of the meds. And there's tools that you can use. There's the RDOS, the Respiratory Distress Observation Scale, which has some evidence, maybe not as it pertains to like an ECMO patient, but to assess whether or not the meds are working. And so, when you don't know, I recommend, being a little bit more conservative. But the evidence out there, the literature out there is scant. When I was writing up the case of this ECMO patient for submission to HPM, I did a literature dive, and one of the cases was written by an upstart cardiologist in New York at the time, and I think the early 2000s, who turned out to be Dr. Oz from Oprah fame, and a failed Senate run, but this was back when he was a real doctor, I guess. But there's not a lot of evidence out there. Um, uh, and so it's obviously an area that needs exploration, but the best I've been able to come up with is that sort of pre-bolus before these interventions go away, and then utilizing available diagnostic tools like the RDOS or Respiratory Distress Observation Scale, which may have been mentioned in other lectures, but it's available. It's a very easy to use table. It's available online. I can actually share a link to it in the chat, or if anyone else has that handy.
Yeah, that'd be helpful. In fact, if you could do that, I'll include that in the posting on the YouTube post.
Sure, great.
Related to that, and I'm thinking this really simplistically, would it not also follow that if we're having a difficult time delivering the drug into the receptors that would help to relieve pain, that we would also see a reduction in the likelihood of side effects, because you're not getting the drug to where it could produce the side effects. And therefore, we could argue to be even more aggressive to try to, push, whatever we can to get the drug in there. I'm just surmising here. I don't have any specific.
I mean, that's a very interesting thought and question. I think in my experience, these patients don't live very long. You stop VA support, VA ECMO, you stop pressor, high dose pressors, you stop those things, and it's going to be, minutes, not hours typically. And so if you find yourself in a position, where patients are developing toxicity to morphine or having myoclonus or something like that, that would be, I would say, less common in my personal experience, but I don't have a ton. I'm sure that other people have had their own experience. So I'm curious what people have seen out there.
There's a comment in the chat box. I don't know who it's from. It's F000169. How are the reasons for stopping ECMO different between the two case studies? And I think this is a great point. Wouldn't the absence of cardiac activity be even a more valid reason that ECMO cannot be a bridge to any other therapies? So it seemed pretty obvious that it can't no longer a transplant candidate. So you stop the ECMO because they're not going to go to lung transplant. But that is even sort of more compelling. We have a heart that is at standstill and probably isn't coming back. So would that not also be, from an ethical perspective, just as valid a reason to discontinue?
That's a great question. I think, you know, the team, the sort of the ICU, cardiac ICU, ECMO team had that same question. Like they had identified that this poor guy was in a persistent, um, you know, critical cardiogenic shock state that was non-survivable. And so we were really brought in at the final sort of recognition of that and tasked with helping a family, navigate that reality. And so you're absolutely right. I mean, this was, they did everything, right? This lecture is called Doing Everything. This guy got everything, and it wasn't enough. And but these are the patients that they throw the kitchen sink at. A young guy, young children. He gets everything that the hospital can provide, and unfortunately for him, it wasn't enough.
And
Good
so
question.
this should be another fun topic to discuss sometime, because you pointed out the fact that he gets everything. You also commented the fact that he's young. He just got back uh, from Florida with his family, and there's a huge emotional component to that has nothing to do with medicine. And I think that gets into some of the implicit bias issues that can influence how we decide to proceed and to intervene with patients based on not just age and our impressions consciously and subconsciously of their family structure, but now starts getting into considerations of socioeconomic status and race and other things that might influence how much we give and how long we give it. So we're not going to solve that in the 3 minutes we have left.
No, that's a talk in and of itself. Yeah, that's really true. I'm glad that you brought that up. Of note, both of these the patients in these cases were African American, and large families, lovely families. The first case is a woman who was later in life. But yeah, it was that's a very important thing to consider as you approach these patients. I want to thank you guys again for having me. I have to jump off for our clinical morning meeting, but please, I've dropped my email in the chat if you have any questions. I appreciate the thoughtful discussion, and thanks again for having me.